So, Mridul, what we will do, we will have a very brief presentation and go straight to the management, because as Dr. Desai said that we have discussed GOs 2 or 3 times recently. So there is no need to repeat that, because every time then we miss on the surgical part. So make a brief.
Okay. Sure, sir. No.
Yes.
So, sir, my patient is a 40-year-old gentleman who is a shopkeeper from Jaipur with complaints of recurrent episodes of vomiting after meals since last 5 months and pain in upper abdomen since last 20 days. The patient, he was well 5 months back when he started developing vomiting after meals, and initially it was every 10 to 15 days, which was postprandial in nature, and the vomiting was bilious, large amount projectile containing partially digested food, and the episodes have become more frequent over the last 1 month, and now it's currently occurring after every meal, solids and liquids. There's also complaint of pain abdomen since last 20 days, which is in the epigastric region, which is moderate in intensity, does not radiate, and is precipitated after food intake. It is relieved after vomiting. There is significant loss of weight and loss of appetite history, sir, with 14 kg lost in last 6 months. In the negative history, sir, there is no history of hematemesis, melena, jaundice, no fever, night sweats, no palpable lump in abdomen, no dyspepsia, early satiety, no abdominal distension, no history of any chronic pain, regular NSAID or PPI use, no back pain, bone pain, hemoptysis or respiratory distress, and no history of decreased urine output currently. He was initially managed for these symptoms elsewhere 5 days back, and he received some treatment with IV fluids, and there was an upper GI endoscopy done after Ryle's tube insertion. Biopsy was taken, and also he gives history that a USG guided procedure was also done, after which he was subsequently referred here. Past history, so there's no known comorbidities or previous surgery. Family history is not contributory. Personal history is he's a non-alcoholic, non-smoker. He's a regular tobacco chewer since last 10 years. Appetite is reduced since last 20 days. Regular bowel and bladder habits, and sleep is undisturbed. To summarize, he's a 40-year-old gentleman, sir, non-smoker, non-alcoholic, without any comorbidities, presented with recurrent episodes of large volume postprandial bilious vomiting since last 5 months, which has progressed in last 1 month and is associated with upper abdominal pain. There is significant associated weight loss and appetite loss.
So based on this history, what is your assessment?
Sir, based on this history, my assessment is that there is definitely a case of gastric outlet obstruction, because justified by the large copious amount of vomiting which is postprandial in nature. But the fact that he is having bilious vomiting, it suggests that there is an obstruction distal to the level of D2 or ampulla. And because he has significant appetite loss and weight loss, it would incline me to think towards a malignant etiology.
Possible site?
Possible sites are uncinate process of malignancy of the uncinate process may present this way. Also, malignancy of the duodenum itself is another differential I have in mind. Another differential, because he's from the northern part of this country, so CA gallbladder, which is growing downwards and is causing compression, extrinsic compression over the duodenum, is a possibility I would like to keep. Another possibility I want to keep, sir, is mass arising from the mid body or body of the pancreas, which is causing compression.
Yeah, so duodenum is all right. Uncinate is okay. Body of pancreas is okay. But CA gallbladder, when it involves the duodenum, which part of duodenum does it involve?
Usually it's the first part, so it would non-bilious vomiting, but it's just a rare possibility. I would
it's very unlikely that CA gallbladder will involve post-papillary, that is the distal half of the D2. So
right,
your first three differentials are acceptable. Yes. And CA head pancreas causing gastric outlet obstruction without jaundice is very, very unlikely.
Yes. Will I proceed, sir, with the examination?
Yes, please carry on.
So on examination, sir.
Sorry. go back to the summary. I think in the summary, it is important to mention no previous history of acid dyspepsia,
Okay, sir.
because we know that the commonest cause of gastric outlet obstruction is benign. So I think an important negative point should also be included in the history.
Okay.
Also, you need to mention large bowel symptoms because transverse colon malignancy with metastatic deposit in the root of the mesentery at the base of the mesocolon can cause third part obstruction and fourth part obstruction. It's known to cause that. It's not common, but it is seen. Advanced growths, especially like this, where he has lost a lot of weight, lot of appetite, loss of appetite, you should keep that in mind. But
Yes.
he would probably have some colonic symptoms if it was so far advanced.
There was no alteration of any bowel habits, or there was no history of any GI bleed or melena also.
This is strange. When there is gastric outlet obstruction and vomiting, his stool output should reduce. He should have less stools. He should have constipation. He should have hard pellety stools should be there. That's typical of gastric outlet obstruction. That's why we were always taught that in gastric outlet obstruction, prepare the colon as well, because fecolids will be there in the colon.
Look, synonym used. What Dr. Anand is pointing out that is it okay to call it gastric outlet obstruction, or should we call it duodenal obstruction because the vomiting is bilious? I mean, semantically he's right, but I think many texts include any level of obstruction up to the DJ as
Yes, sir. That's why I thought
we
it
say head pancreas. There also some textbooks mention that it causes jaundice and gastric outlet obstruction, although semantically and technically speaking, it is duodenal obstruction.
right.
I mean, for that matter, even peptic ulcer causing obstruction is a duodenal obstruction.
So on examination, he's a middle-aged, averagely built and poorly nourished patient with a nasal tube in situ draining yellowish fluid. He is alert, conscious, cooperative, and well-oriented. His ECOG performance status is 1. BMI is 17.99 kilogram per meter square with a weight of 49 kg. There's no pallor, icterus, clubbing, cyanosis, or edema. There's a palpable left supraclavicular lymph node which is around 2 into 3 centimeters in size, which is firm in consistency and oval in shape. It is immobile and is fixed to the underlying muscle. He appears to be well hydrated with a pulse of 76 beats per minute, blood pressure of 122 by 74 millimeters of mercury, and respiratory rate of 15. He's also febrile. Abdominal examinations on inspection, the abdomen appears to be flat without any flank fullness. The umbilicus appears centrally placed, inverted without any nodularity. There's no visible lump, fullness, scars, sinuses, engorged veins, visible gastric peristalsis or pulsation. All the quadrants seemingly move correspondingly with respiration. And on the hernial orifices, there's no visible cough impulse. To palpate, the abdomen is soft and non-tender. There's no palpable lump or nodularity, no organomegaly, no palpable cough impulse at the hernial orifices, and the renal angles are free. On percussion, there's no free fluid in the abdomen. The upper border of liver dullness is percussed at the fifth intercostal space. The liver span is measured as 12 centimeter in the right mid-clavicular line. The flanks are tympanic, and on auscultation, there's normal bowel sounds heard. No succussion splash could not be elicited because Rice tube was in situ. Per rectal examination, perianal skin was normal, no fissure, fistula, external hemorrhoids, no growth or nodules palpable, and glove finger was stained with normal stools, no blood staining. Rest of the systemic examination was essentially normal. Respiratory system was normal. Cardiovascular system S1, S2 had no murmurs, and neural system, higher mental functions were normal. No focal neurological deficits. So he was
Go back to the inspection and palpation. See, when you have multiple negative findings, you should highlight and separate out the important one. So here the important one is that there is no visible lump in the epigastrium and there is no visible gastric peristalsis. That should shine out. The rest, fullness, I mean, a scar, sinus, engorged veins are not important in this case. In fact, I personally at MCH level I'm fine if you don't mention the unrelated negative findings, although some examiners would insist that it should be as complete as possible. But definitely the related ones, the important ones, lump, fullness, and peristalsis, they should singled out.
Okay.
And in the
Also, lymph
auscultation
nodes.
again,
Sorry, sir. Please go on.
yeah, please.
Yeah. Have you examined all the lymph node subgroups? Axillary,
Yes, sir.
cervical,
I did
posterior
examine
occipital,
the axillary.
Walde's ring.
Yes, sir. The other lymph nodal groups, axillary lymph node group was also examined, but it wasn't enlarged. And
So
rest of
everything was normal. You have to mention it because lymphoma of the paraortic lymph nodes can produce D3 obstruction. That's a pretty common cause again.
yes, sir. There's no other generalized lymphadenopathy. The only single lymph node that was palpable was the left supraclavicular. So, just to add to the summary, on examination, he's an average built, poorly nourished patient, well hydrated with a BMI of 17.99 kilogram per meter square, with a nasogastric tube in C2, and he has an enlarged suspicious left supraclavicular lymph node. Rest of the abdominal examination is unremarkable.
And when
Just
you
quickly.
say left supraclavicular lymph node, you have to be precise. Is it the workhouse node? Is it Troisier sign? Or is it supraclavicular lymph node in general? Because only between the heads of gastrocnemius, if it is present against the surface of scalenus anticus, you can call it Troisier signs positive.
Yes, sir. It was
So
not.
what was it?
It was not in the posterior triangle. It was in the triangle 4, so just anterior to the scalenus muscle, sir. So I would consider it to be Troisier sign positive.
Yeah, so that is more significant.
Yes, sir.
Let's quickly review the investigations.
Sir, so he had some investigations which were already done because he was admitted elsewhere.
Yeah, we will just review them and then go on to the management.
Yes. So he had a hemogram. Hemoglobin was 11. Hematocrit was 33.4. It was slightly lower side. And total counts were okay. Platelets was also okay, 207,000. Blood urea nitrogen was 11.7. Creatinine was 0.8. Sodium was 134. Potassium was 4.2. The liver function test also, sir, was remarkably normal. Albumin was 3.8. Probably owing to the fluid correction he had been given elsewhere. Sir, they had also done an upper GI endoscopy. I don't have the images, but this is the findings they are given. There was a esophagus and stomach were essentially normal, and there was a periampullary diverticular polypoidal mass lesion from the D2 area with partial luminal narrowing, and a biopsy was taken. Actually, sir, he just had one report of upper GI, but he had two biopsies. So they had probably done it on two occasions. The first occasion they got hold of a D2 polyp,
Yes.
and which was a benign mucosal polyp with no dysplasia or malignancy. And second time around they did a biopsy from the D3, which showed no specific lesion, no dysplasia, malignancy, no granuloma, or increased eosinophils.
So when you have a lesion in the duodenum and twice the biopsies are negative, what do you start thinking?
Sir, then it is probably that there's no mucosal lesion. One is the possibility that the lesion might be submucosal, so it would be better to get a deeper biopsy. An image-guided biopsy would be more suitable, like endoscopic ultrasound if the facility is available. It would offer us a better yield.
What are the possible diagnoses? Go back to the endoscopy report. What does it say?
There was a small periampullary diverticula and a polypoidal mass lesion in the D2.
So what more you would have liked to know on endoscopy now with two biopsies negative?
Sir, they have not commented about the mucosal appearance of the lesion,
Yes.
whether it was ulcerative, whether there was any
whether there is any mucosal ulceration, whether the mucosa is normal. Because if they had said mucosa is normal and then two biopsies are negative, you start thinking of a submucosal lesion such as
GIST GIST would be the most prominent one. Or lymphoma
which
also.
lymphoma. Yeah. So these are two things which should immediately come to your mind when, if on endoscopy you say that mucosa is normal or there is an ulcer at one point, and if two biopsies are negative, the moment two biopsies are negative, you start thinking of a submucosal lesion, and these are two submucosal lesions. The third possibility, not a common entity, is a true large duodenal polyp which is causing mechanical obstruction, a benign polyp. But single large duodenal polyp in the absence of any other polyp is not a common situation.
Yes, sir. And given his history, we are more inclined towards finding out a malignant etiology.
Okay, so what next was done in this case?
Sir, he underwent a CECT.
Okay, let's see.
I don't have the video, but these are the cuts we have of the films. This is a contrast enhanced CT scan, which is showing the uh, portal phase at most I can see. So the stomach looks grossly overdistended, and the stomach lining looks very thinned out, but I can't see any thickening grossly on the stomach lining. There are a few liver lesions that we can see. One is here on the right lobe. One here on second. This is probably this is between left hepatic and middle hepatic, and it is above the portal confluence, so it would be segment 4A. These
I'd
are
like to bring your attention towards the scanogram, which is showing a very thin, elongated person.
yes, sir.
That seems to be his default build. So, was he a hefty man before, or instead he lost 14 kilograms?
Kilograms
Would it be
also.
superior mesenteric artery syndrome that has caused his weight loss? Before you get to those cuts, that's why I wanted to ask this question. Have you considered that as a possibility?
No, I had not considered that as a possibility, sir, because there was no abdominal angina as such. The pain.
You won't get abdominal angina in superior mesenteric artery syndrome.
This
That's
guy is not
compression of
talking
the.
artery ischemia. He's talking of SMS syndrome.
Yes, sir. The
What is
obstruction.
SMS syndrome?
Sir, it is obstruction of the D3 because of the angulation of the takeoff of SMA.
Acute angle between the SMA and the
And
aorta,
the aorta, which presses the
could be
D3.
precipitated by a recent sudden large amount of weight loss for some reason. And notice how gastric outlet obstruction alters the anatomy. See where the pylorus and the first part of duodenum are seen. So whenever there is gastric outlet obstruction because of distension of the stomach, the anatomy gets altered. Okay, show us the lesion. Probably you will see it in the next.
Yes, sir. The next slide. This is the D1 going forward. Actually, we're just going back. So the pylorus is probably coming here, and then we're following that. The duodenum also seems to be over distended. And out here, sir, this is the region of D2 because we can see the common bile duct here. And there seems to be some amount of thickening here and scalloping also from the medial end of the duodenum. There's definitely some hyper-enhancing lesion here which continues.
Yeah, so the second cut in the middle row, you can see that beyond the dilated first or second part of duodenum, you see this thickening of the wall of the second, third part of duodenum just behind the SMA,
Yes, sir.
which is
Out
circumferential.
here in the last cut in the second row, we can see that the duodenum is starting to collapse. So this might be the transition.
Yeah, that actually is the genu of the duodenum, so that is okay. But in the second and third cuts in the middle row, you can see the thickening in the third part, thickening of the wall of the third part of
in
duodenum.
the middle part also. If we see the outline of the pancreas, the body of the pancreas seems to be fine. It is although compressed by the stomach anteriorly. We are seeing the head is also seen fine, but the uncinate and the duodenum are the fat planes are quite indistinct. So I'm not sure whether the thickening is arising from the duodenum or it is part of the uncinate process.
No, but if it is an uncinate process growth which is involving the duodenum, it will involve only the anterior wall of the duodenum or the superior wall of the duodenum. Here, you see in front of the aorta and IVC also, the posterior wall of the duodenum is also thickened. In fact, in the second cut, in the middle row, if you see the air in the duodenum, more thickening is in the posterior wall. There is less thickening in the anterior wall. That doesn't fit in with uncinate process. In the uncinate process, it will be the anterior-superior wall of the duodenum, which is more likely to be involved. And here, it appears as if it is a circumferential thickening, which again would not be there in the uncinate.
Okay.
Follow the body of the pancreas into the head and see if there is anything in the uncinate. Only thing is that in the third
medullary
cut,
duct is not
This
dilated.
region,
yeah, in the fourth cut in the top row, third and fourth cut in the top row, behind the stomach, the concavity of the stomach, yeah, this hypodense area, yes. You can see it better in the fourth cut.
yes, sir, it's
Yeah. So I don't know whether that is a hypodense mass in the.
and also, sir, the fat planes around the aorta also very indistinct. Like this might be a nodal mass. Not exactly sure, but
Left para-aortic.
yes, sir.
It is seen in the first cut in the middle row also. The left para-aortic node. You see the first cut in the middle row. To the
Yes,
left
sir.
of the aorta, you see
Yeah,
this.
that's
Exactly, we won't be able to see the mass that's compressing the duodenum.
Yes. So whether this mass, which we are seeing in the third and fourth cuts in the first row, is infiltrating the third part of duodenum.
There is a fat plane between the node and the pancreas and duodenum. We are able to see a clear fat plane. So at least it's not compressing directly.
Whether that also is a node at the root of the superior mesenteric vessels. And the primary, to me, it appears that primary is in the duodenum and these are all nodes.
And could it be tuberculosis becomes the next question because that is commonest in India.
Okay, let's carry on.
This is the coronal section, sir. Here also we can see that the thickening is primarily here next to the third part of the duodenum. Here we see that the medial end of the duodenum has been scalloped. This was the report, sir, provided.
Yeah.
That there's a circumferential mural thickening in the third part of duodenum with evidence of shouldering at the proximal and heterogeneous enhancement of thickened duodenal walls. Fat planes with uncinate are indistinct, and there is suggestion of diverticulum along the anterior part of second part of duodenum, and mild surrounding fat standing is seen. Upstream dilatation of duodenum and stomach with stasis of oral contrast, and multiple enlarged necrotic lymph nodes in the adjoining mesentery and retroperitoneum, largest being 24 into 16 millimeters. These lymph nodes are causing encasement of the left renal vein and mass effect on IVC with preserved contrast opacification. And with the liver also, they have mentioned that there are multiple variable size hypodense lesions on both lobes, with the largest measuring around 10 into 10 centimeters with subtle peripheral enhancement. HBR is not dilated, and rest the gallbladder and the CBD look okay. Pancreas is otherwise normal in size attenuation. There's no focal lesion or calcification, and PD is not dilated.
So if you have a patient where two biopsies were negative, you are seeing thickening of a part of the duodenum, you are seeing multiple necrotic lymph nodes, what comes to your mind?
Sir, there is after seeing the CT, we've also seen that there are multiple liver metastasis. And also,
they have reported these liver as well as metastasis, not cyst?
Yes, sir. Yes, sir.
Mm-hmm.
They're likely metastatic deposits, sir.
But what I was trying to hint at is that when you have a submucosal lesion or repeated biopsies are negative and you see multiple large necrotic nodes, at the back of your mind, you should keep tuberculosis also as a possibility, because lymph nodes in lymphoma are usually smooth, large, and solid. They rarely undergo necrosis. It is metastatic nodes and tubercular nodes which will show evidence of hypodensity suggestive of necrosis. So if you see large necrotic nodes, you keep these two possibilities. Obviously, if the liver, considering the left supraclavicular node, considering the liver SOLs, those nodes probably are metastatic. But otherwise, when you see a lesion where you are not thinking of malignancy and you see large nodes with central necrosis, you have to keep possibility of tuberculosis also in mind.
So the lack of fever or evening rise of temperature does not essentially rule out tuberculosis, right?
Sorry, say again.
The lack of fever or evening rise of temperature in him, there's no history as such. That does not essentially rule out tuberculosis.
No. It's not that all patients with abdominal or any extrapulmonary tuberculosis will have pulmonary or contact or anything. It can occur with. If it is there, it supports the diagnosis, but it doesn't. A normal chest X-ray doesn't rule out a diagnosis of extrapulmonary tuberculosis.
Only 20% of people have pulmonary tuberculosis when they have abdominal tuberculosis. So, oral route is the most common cause. I couldn't appreciate the liver metastasis. Could you go back to the CT and show us again?
Yes, sir.
Maybe enlarge the film.
Sir, here in the right lobe, there is one. This is probably segment 7, but we can't exactly tell because we're not able to have the video. But here definitely
Looking more like focal fat sparing, not rather than as because it's triangular. This thing more than it's got a round or a mass-like appearance. There's one here in segment 8.
Yes, and here
Got it,
also
maybe.
Appears like that,
there is
but
definitely
not
one
sure.
here in caudate as well. Yes.
I thought that they are probably benign cystic lesions, but anyway. Okay, we have anything else? Any more information on this case? Otherwise,
No,
we'll go on.
that is about it.
Okay, so for the sake of discussion, let us say that there was no supraclavicular node, there are no liver metastasis.
Sir,
Some of these nodes are.
There is also one thing, because he had undergone already a USG guided FNA. I can show that
From?
Sir, from the liver as well.
Okay, that's fine. So in this case, what would you do with whatever information we have now?
So the prime intention would be for palliation. So the main objective would be to palliate the symptoms of gastric outlet obstruction. So the options would be either put in a metallic stent if he's agreeable, or surgically to bypass procedure like a gastrojejunostomy.
If you decide, or if the patient somehow decides for a surgical option, what surgical procedure would you do in this case?
Sir, anticolic isoperistaltic loop gastrojejunostomy.
Is gastrojejunostomy the best surgical option?
We could add a bronze, no, but there's no reason.
Would you consider a duodenojejunostomy?
I haven't ever seen it, so no experience with that.
The obstruction is at D2, D3, or almost D3. So you have the entire C loop of duodenum, which is dilated, which is available. If you do a gastrojejunostomy and pylorus is intact, it may not be the best option. So just as what you do in a duodenal atresia or in an annular pancreas, if the duodenum is soft, supple, you are far away from the tumor, I probably, if at all I do a surgical bypass, I probably would do a duodenojejunostomy. That would also take care of the problem of bile reflux gastritis, which is a problem with a simple loop GJ. But the treatment of choice in a case like this, if availability and affordability is not an issue, is a self-expandable metal stent, non-surgical.
Yes.
option. Okay, so for the sake of discussion, let us presume that there is no left supraclavicular node, there are no liver metastasis. You see this thickening, and biopsy we don't have. Twice biopsies are negative, and there are some of these large necrotic nodes. Now, what will you do?
So would definitely proceed for a US guided biopsy. Would attempt for it.
Okay. Not available, not affordable, inconclusive. It happens. So many times we don't have a tissue diagnosis.
Sir, if we assume this to be arising from the D3, as the scan is showing the D3 and involving the MCM, then the surgical procedure of choice would be to do a pancreatic duodenectomy.
What would
So
be
there
a
is no
differential
option.
diagnosis other than carcinoma duodenum? What are the benign possibilities are there?
So chronic pancreatitis, but there is no history as such of abdominal pain proceeding, or he's not even an alcoholic. There's no history of long-standing abdominal.
What is pancreatitis?
That isolated pancreatitis that happens in the pancreaticoduodenal groove, sir.
Could it be that? Not in this case. You have to consider benign possibilities because
Yes.
2 biopsies have been done, both are negative. If US had been done and FNAC was negative, there's 3 biopsies. So you should keep benign causes in mind because benign causes, you are not writing off the patient.
We would, sir, want to then exclude tuberculosis as well. Maybe get a
How would you do that?
gene expert or a TB. We would do a gene expert probably to rule it out, or TB gold.
Quantiferon TB gold is not to be done in India. Tuberculosis Society of India has issued guidelines clearly saying that those populations where tuberculosis is endemic, quantiferon test, gold test will be positive in majority of them. So it's not very beneficial. Gene expert and FNAC and PCR on the FNAC sample would be probably the path to go by.
And also tumor markers, they may not provide the diagnosis, but they might provide some support.
On the contrary, they'll mislead you because tumor, if there is D3 obstruction, there's gastric obstruction. CA19-9 can rise, CA can rise. Benign causes of CA rise and CA19 rise are there. And he's not a smoker, but if he's a smoker, then it might be raised because he's a smoker.
Yes.
So you shouldn't do tumor markers to diagnose anything. It's only for follow-up and not for staging or diagnosis. That's very clear.
The question is, if you see a thickening in the duodenum and you cannot establish a tissue diagnosis, we don't know what it is. How do you manage a patient like that? You don't know whether it is benign or malignant. You don't know what it is. So how would you manage? These are practical problems. You will encounter such cases. Sometimes even in the stomach, it is not possible to get a tissue diagnosis. Okay, let me put it directly. Since you don't have a tissue diagnosis, you don't know what it is, so you can't rule out malignancy, isn't it?
Yes.
Wall thickening, short duration of history, and nodes. So what are the features which will decide whether this lesion, which is in the third part of duodenum, is resectable or not?
Sir,
what structures would you look for in the CT scan?
So whether it has the vascular invasions, or whether it has invaded the SMA, or if there is invasion of the SMVs, of course, if it is reconstructible, then it is not unresectable. But
so your answer should be, the first thing I will look at is the superior mesenteric vessels, especially the superior mesenteric artery.
Yes, sir.
Isn't it?
Yes.
And then, because it is in the D3 means it is lying, as you saw in the CT, it is lying between the SMA and the aorta. There could be direct infiltration of the aorta. There could be direct infiltration of the IVC. And what else?
The mesocolon, yes. Whether it has invaded the mesocolon, the small bowel mesenteric, is it involved? That will also preclude a resection.
So which are the structures which, if involved, will make it unresectable, and which are the ones which can be resected? You have
Sir,
to classify into those.
sir, involvement of SMA more than 180 degree is unresectable.
CA
Involvement,
duodenum. You're talking about CA duodenum, not CA pancreas.
sir,
Yeah, but I
involvement.
presume it would be the same, isn't it, Rajen?
Not
Artery
very clear,
involvement.
sir, from literature. Not very clear, but most of these
Mhm.
guidelines are for CA head of the pancreas. Nobody
Mm.
talks about cholangio CA, or they don't talk about duodenal CA when they talk about this
Yeah.
resectability criteria on pancreatic duodenectomy.
And even SMV, although you said that whether it is a resectable, reconstructable segment, but you have to understand that now we are talking not of the same part of SMV which is involved in a CA pancreas. We are talking at a much lower level where all the tributaries, all the divisions of the SMV also would be involved. So this part of SMV is even more difficult to handle than the part which will be involved in the CA head pancreas, because we are now talking of more distal part of SMV. So theoretically speaking, you are right that SMV doesn't make it unresectable because you can resect and reconstruct it. But reconstructing the part of SMV which has already giving rise to multiple or receiving multiple tributaries from small bowel is not an easy job, and you may end up sacrificing a large part of the proximal jejunum which is draining into that part of the SMV. So SMA, obviously aorta and IVC,
Small bowel,
then
sir.
SMV, and
Small bowel
which other
mesentery.
organ? We just
First,
discussed.
first jejunal vein also, sir.
Mhm.
Uh,
Yeah, that's what I was saying. Here it is not only first, it is second, third, and fourth jejunal veins also, because you are talking of a few centimeter away from the point where it is joining the portal vein. You are talking of the distal part of the SMV. And the body of the pancreas, isn't it? We were discussing that body of pancreas can come into duodenum. The same way duodenum can go into body of pancreas, third part of duodenum. So if body of the pancreas is involved, then you will have to give a serious consideration whether you are going to resect, because depending on the location, the site, and the extent of involvement, whether it will be amenable to a median pancreatectomy or a distal or a proximal pancreatectomy, whether you want to do a PD for a duodenal carcinoma and all those things, isn't it? But before that, this is a case where we started with that we have no diagnosis. So when you go in, what is the first thing you would like to do?
Staging laparoscopy, so to look for the peritoneal mets, to look for the mets on
Yes,
the
yes.
wells, that would be the first step. And
Okay.
once
Suppose
after,
there is no peritoneal spread, there are no liver metastasis. Then
yes, sir, then the first step would be to do extensive cauterization and sample the interaortic cable nodes also. We'll look for that, whether if they are involved, then also if we consider them to be
you don't
metastatic.
need to even cauterize. You saw that large node in the root of the mesentery, which will be obvious. So, whichever large nodes you see, whether with or without cauterization, you take one or two of these nodes out. You can just bisect them on the table because they are necrotic. If you see caseous material, you know it is tubercular. If you don't see caseous material, if it is all solid and it is large, you suspect it to be metastatic, you send it for frozen. So that is how you proceed, isn't it? Suppose a gross examination of the node or frozen section tells you that it is not adenocarcinoma, it is tuberculosis, it is lymphoma, then obviously you will retract. You will
Yes.
not plan for a resection. So, in a patient where you don't know the diagnosis, that is how you gradually proceed. First, you do the simpler, less invasive investigations, then you do more invasive investigations, and it is only as a last resort that you would like to do a resection without a diagnosis.
Sir, means if the facility is available, will a laparoscopic ultrasound help in this patient?
How?
To, I mean, we already have the scan, we already have a CT
What
scan.
information will laparoscopic ultrasound give you, which CT has not been able to give you?
I'm not exactly sure. I don't think so. That's why I just wanted to confirm.
Except you can say a small intraparenchymal metastasis which was not seen on CT or a SOL. I'm saying surface lesion you will see on staging laparoscopy. So theoretically yes, but practically speaking, now what we are looking for is a tissue diagnosis,
Yes.
and our dilemma is between malignancy tuberculosis and lymphoma. None of these three things can be settled by laparoscopic ultrasound, isn't it? It is only the gross examination, as I said, that typically a tubercular node, if it is large, if it is necrotic, if it is seen as necrotic on CT, you just bisect it with a knife, you will see that white, creamy, yellow, cheesy material, the caseous material. That almost 99% establishes the diagnosis of tuberculosis. Lymphomatous nodes are always solid. You bisect the node, the cut surface just bulges out. So they are fleshy nodes typically. Metastatic nodes can be firm to hard, can have necrosis, but you will not see caseous material. You will see necrotic tissue, brown, red necrotic tissue. You will not see the classical caseous material. But obviously, you will have to rely on a frozen section examination. So since these nodes are quite large, I presume that a node should give you the diagnosis. It is very unlikely that node will not give you the diagnosis in a case like this.
Yes.
And ultimately, as it happens, if it is a resectable lesion, then you would like to resect it. And when you are doing a resection, you would like to do resection as if you are doing a resection for malignancy, because you don't want to undertreat. So the point which we were discussing yesterday in the master class, that if you see a right iliac fossa mass and you don't know what it is, then you do a formal right hemicolectomy thinking that it is malignant. If it turns out to be tubercular, it is an overkill, but acceptable. On the other hand, if you do a limited ileocecal resection without lymphadenectomy and it turns out to be malignancy, then your treatment was inadequate, incomplete. But third part of duodenum is not an easy option, because resection of third part of duodenum is not an easy thing. There are so many important adjacent structures which you have to be sure that they are not involved before you start thinking of resecting the third part of duodenum.
Mridul,
Yes, sir.
what is the mobilization you'll do for third part of the duodenum to expose that area for either a duodenal jejunostomy or for resection?
Sir, we will open the lesser sac firstly to visualize the third part of duodenum. Also, wide cockers and a cattle brush maneuver need to be done.
Cattle and brush, you should say first, because rotating the whole colon upwards will expose the duodenum very well at the base of the mesentery. Even opening the lesser sac is not required, because most of it will be below the lesser omentum. Below the greater omentum.
And nothing on the left side?
It's a medial visceral rotation, a Mattox maneuver, I think. Sure.
You have to mobilize the duodenojejunal flexure also. It is the same process as you do in Whipples. That is how you take the entire proximal jejunum to the right side,
Right side,
isn't it?
yes.
With the specimen. So that is what you have to do, whether you are doing a Whipples or you are doing only a third part duodenal resection. If you are planning to do only a palliative bypass in the form of a duodenojejunostomy, then probably the DJ flexure mobilization may not be required. Then you just cockerize the duodenum, because for any suture line on the duodenum, whether it is for gastroduodenostomy, whether it is for choledochoduodenostomy, whether it is for duodenojejunostomy, the duodenum has to be mobilized so that it becomes like a small bowel loop which is free, so that there is no tension on any of your. Theoretically speaking, you can say jejunum is freely mobile, so I can put the jejunum on the non-mobilized duodenum also. Yes, you can. But it is always better to have a mobilized duodenum before you put any suture line on the duodenum. Ajay,
what are the artery first approaches?
D3 के बारे में कुछ tips.
Not sure, sir.
Artery first, posterior, transmesocolic, anterior.
Yes, sir.
You all should read Dr. Shailesh Srikhande's article on
article,
the
I know. Really well written.
Yes, sir.
Dr. Ajay, I would like to give you some tips on D3.
Sir.
I Mridul, one thing from the beginning, that CA body of pancreas less commonly causes the duodenal obstruction. It is usually a gastric symptom which will come before that. So body of pancreas causing a duodenal obstruction is less common. It is more due to the nodes over there. Second thing which I felt was that T3 obstruction due to malignancy. It is almost always unresectable because of the vessels closely abutting it. So because in case you try to mobilize that part of duodenum, it is next to impossible. Third thing is the duodenum when you are having a lesion in the D3 lesions, whether it is a perforation of the duodenum, malignancy of the duodenum, tuberculosis of the duodenum, whatever. If you want to resect that portion, you have to cauterize the entire duodenum and you have to mobilize the D3 D4 genu. When you are mobilizing the D3 D4 genu, the most difficult part of the surgery is the D3 D4 genu. When you're mobilizing, then mobilizing it from the pancreas, because there will be lots of vessels over there and nodes over there. That area causes the problem. And of course, as Dr. Desai is saying, that the SMA first approach, you have to first safeguard your SMA, because if your SMA is not being safeguarded, once you have done the entire procedure, now you can't safeguard your SMA. You have done part of the job. Then it becomes impossible to revert back. Second thing, for a malignancy, if it is a patient with a disseminated malignancy, though Dr. Kapoor said that he would prefer a duodenogenostomy, but just for a palliative procedure, I think gastrojejunostomy can be just sufficient enough, because he is having,
Safer.
we don't expect that he does not have a long life. And doing a duodenogenostomy in this patient might be a more difficult procedure for a disseminated disease. But if it is not a disseminated disease, if it's a benign disease or tubercular, I think duodenogenostomy is always a good option, because the patient has to live next 20 years now.
Yeah, I think I'll
Sir, a
agree
doubt
that.
I had a doubt. Would you do it even in the presence of peritoneal deposits?
No,
Because
sir.
it doesn't function well.
That gastrojejunostomies usually don't function well. I agree with that. Whether it is gastro or duodenojejunectomy, duodenojejunectomy will definitely not do with metastatic disease. But GJ, it has an intrinsic problem that it does not function. That is the problem with GJ and when a patient with obstructions. Therefore, GJ has been tried. You will never hear about a isoperistaltic, antiperistaltic, retrocolic, anticolic, blah blah blah. So many variations of these with the loop jejunostomy, with the end jejunostomy, with gastrojejunostomies. You will not see so many procedures with the other bypass procedures. This only gastrojejunostomy has, and even we have tried that we have made a hole into the stomach rather than making a cut into the stomach, which we felt that it is functioning more. After that, it has gone out of vogue because we are no more doing a gastrojejunostomy nowadays. But definitely, gastrojejunostomy has an inherent problem of not functioning that you have to accept at every point in time.
So
I
I
agree,
think
sir.
from starting point, the best palliation is non-surgical, self-expandable metal stent. If at all you have to do surgery in presence of peritoneal dissemination, you would be very hesitant. And I will agree with Ajay that GJ is definitely much safer than a duodenojejunectomy. If it is benign condition, then probably duodenojejunectomy. But if it is advanced malignancy, I would agree gastrojejunostomy. Although you have to be prepared and you have to prepare the patient that the GJ may not work. There is a question from Dr. Vihar Kotecha about a loop versus Roux-en-Y. I mean, if the life expectancy is short, to make it technically simple, most of us would do a simple loop GJ. But yes, for a benign condition, most people would prefer to do a Roux-en-Y, because with a loop GJ, the problem of bile reflux and reflux gastritis sometimes can be very, very
Sir,
troublesome.
I have a question. Would we require to do a bronze jejunostomy also in addition, or is it not required?
No, that is what I'm saying, that if you are doing it in a patient with disseminated malignancy where life expectancy is not going to be more than a couple of months, then probably a simple loop GJ, to keep it simple, to have only one suture line, most people will do that. And actually, by choice, today nobody will go in to do a bypass, because you have stents available. It is only when stent is not available, not affordable, that perforce we do these procedures. Ideal is a Roux-en-Y bypass, but in a patient where you know that patient is not going to live for a few months, you want to keep it technically simple. So most people probably would just do a simple GJ and come out. Okay. Thank you. Thank you, Mridul. Thank you very
Thank you.
much. Thank you, everyone.
Thank you, sir.